All right, hello everybody. My name is Dr. Roseanne Storer. I am currently a long-term care pharmacist over at Heartland Pharmacy Health Systems. I graduated from Midwestern University College of Pharmacy in the year 2015, and today I will be talking about healthcare and cultural considerations in the Middle Eastern population. So just a few learning objectives that I would like you to know by the end of this lecture. I would like you to understand the core family dynamics of the Middle Eastern patients and the Middle Eastern culture. So we'll talk a little bit about Middle Eastern culture just to get you a little familiar with it. By the end of the lecture, I would like you to be able to describe the common disease states that are in Middle Eastern patients, to be able to identify ways to obtain information from reluctant Middle Eastern patients, because that's always tricky. And it's even more tricky and more difficult when it's a patient who does not speak English as a first language. I would also like you to be able to identify some barriers to successful patient encounters and how to overcome them, and to be able to recognize ways to facilitate healthcare delivery to Middle Eastern patients. So let's go ahead and start by defining a Middle Eastern patient. So the common misconception is that Middle Eastern patients only come from the area, from the Middle East, and they are Arab or Muslim, and that is not true, and it is not correct. A Middle Easterner is actually a person from the area around the Middle Eastern region. They stretch all the way from Turkey to Northern Africa and then eastward to Iran. Let me see if I can figure out how to annotate as I'm doing this here. So if you see how it stretches all the way from Turkey to Northern Africa and then eastward to Iran. So that does not only include Arabs, and it does not include Muslims. So Middle Eastern can be Persian, they can be Turkish, they can be Jewish or Arab. The Middle East in general is known as the cradle of Western civilization because from the Middle East we have three very large and major religions: Islam, Judaism, and Christianity. They all sprouted from that region. So just a little background on immigration. In the 1600s, the first Arabs arrived on the shore of the New World. By 1875, we started seeing some more Arab communities around the United States forming here and there. In the 1970s, there was a lot of political instability in the Middle East, which caused a lot more Arabs to immigrate to the United States. And today we have millions and millions of Arabs that reside all over the United States. Common languages of the Middle East, again, a common misconception would be that they only speak Arabic. Arabic is the dominant language, so that is true in that aspect, but it is not the only language that is spoken in the Middle East. In fact, we have a lot of Hebrew-speaking Middle Easterners, Turkish, Farsi or Persian, Kurdish, and Dari and Pashto. Now, to make it even more confusing, within the Arabic language, there are several dialects that exist. So we have the common Arabic language, but then if you go to Egypt, they speak a slightly different Arabic language. If you go to Morocco, for instance, they speak a Darija, which is another different Arabic language, and so on and so forth. So there's Arabic as a dominant language and different dialects within the different Arab countries, along with other languages like Hebrew, Turkish, Farsi, and Persian. So just to give you an idea of what the Middle Eastern diet is like, it's very important as a future pharmacist to know that diet, exercise, medication all go hand in hand when you're dealing with a patient. So common foods in the Middle East include dates, lots of olives, wheat, rice, legumes, and lamb. So your common Mediterranean diet. They eat bread or rice almost with every single meal. It's very odd to find a Middle Eastern family cooking something without bread or rice. So their food is often stew. So they'll cook a lot of like lamb stew or chicken. A lot of it is grilled and some frying as well. So if you can think ahead, you can already tell that they are using not so healthy Middle Eastern diets. So eating practices and food preferences, this is very crucial to you as a future pharmacist. Practicing Muslims do not eat foods containing pork or consume anything with alcohol or anything flavored with alcohol. Practicing Jews do not eat any foods or products containing pork as well. So just to go back to the first 2 points here, how would this affect you as a future pharmacist? There are a lot of gelatin-based capsules, for instance, NyQuil capsules, multivitamin capsules, or multivitamin gummies, for instance. So a lot of Muslims and Jews might come to your counter and ask if these gummies have been made with pork or pork-containing gelatin. If the capsule has any sort of gelatin, or the soft gel, a lot of the soft gels have pork products. On the other hand, a lot of others have beef, so that's the alternative that you need to be looking for. In terms of alcohol and medicine, elixirs are alcohol-based, and a lot of Muslims might refuse elixirs because they do not want to consume any sort of alcohol. So that's just something to keep in mind when dealing with these types of patients as a future pharmacist, or even as a student pharmacist when you start going on your rotations. Fasting is very common for Muslims who observe the month of Ramadan annually. So the Muslims fast, and let me define the fast. We fast from sunrise to sunset, okay? Whatever period it is of the year, that's determined Islamically and by the moon and the lunar calendar, but we fast from sunrise all the way to sunset. Now, that is a problem because we not only abstain from food, but we also abstain from drinks. Nothing goes in. So a lot of people think, can you eat? Can you drink? You cannot drink. If you cannot drink or eat, then you also cannot take medications. Now, Islam is known to be an easy religion. It's not meant to make things harder. So there are more patients that have more complex disease states, and they need to take medications on time, scheduled at all times. Those patients are exempt from the Muslim fast. They do not have to fast. But you will have patients who want to be advised on how to take their medications while fasting. So the best case to do, or the best thing to do, is to look at how the patients are taking their medication and try to work around their times. It's usually no longer than in the United States, because of the sunrise and the sunset and where we are located geographically, it's no more than maximum a 12-hour fast, if that. Sometimes it's not even that long. So these patients usually eat these Muslim patients usually eat a meal in the morning, and then the sun rises, so then they start their fast, and then they eat another meal when they break their fast, and they get to eat all they want until sunrise again. So they get to eat, meaning you have 2 windows to administer medication. In the morning, if let's say it's a BID dosing where it's twice a day, then you have in the morning they can take their first dose, and then they can take their second dose when they break their fast, and there they go, they're done. If it's once a day medication, then they can take it in the evening or in the morning. So it's very easy to work around it, but these are very common questions that come up to pharmacists and to doctors at all times when Muslims start fasting. Now, another thing to keep in mind is diabetic patients, especially if they are on insulin. If they are on long-acting insulin, they can take that right when they eat or right after they're eating. But if they are on a sliding scale, for instance, like let's say they measure and then if it's a little high, then they get to take 15 units. If not, then they can take 10, and so on and so forth. They might not need that short, rapid-acting insulin while they're fasting because there's no food that's going inside their bodies. So there's no need for that insulin because there is no glucose. So that's just something to keep in mind and to follow up with your patients. Very interesting, but very solvable, very easy to handle. American Middle Easterners now prefer an American breakfast. So we talked about the Middle Eastern diet involving a lot of bread, a lot of rice, a lot of stew, a lot of cooked things, grilling, frying, oils, lamb. So if you can tell, it's a lot of carbs and a lot of fat. But through culturation and through immigration, we have a lot of American Middle Easterners who prefer now an American lunch or breakfast, but they might still have a Middle Eastern dinner at home. So the diet of the American Middle Easterners is different than the diet of the Middle Easterners back home. So a lot of Middle Easterners believe in natural remedies. This impedes your ability to fully get into medication adherence and medication compliance with these patients. But just to give you a history of where all of this is coming from. After the fall of the Roman Empire, the Middle East became the center of scientific and medical knowledge. So people would travel to the Middle East if they had any types of ailments or diseases that they didn't know. To see the best doctors, patients would travel to the Middle East. Ibn Sina or Avicenna wrote the Canon of Medicine. And that was a 5-volume encyclopedia. And it was used as the standard book of medicine for 600 years. So 600 years they were going by this book. Some of the first professional models of pharmacy were actually seen in Baghdad. And Islamic physicians knew early on that it's not just medicine that is needed to cure somebody or to treat someone. We also need diet, regulation, and exercise along with medicine. But again, back then, the medicine was natural remedies. It's just a bunch of natural remedies. So what are some of these natural remedies that are still practiced today in Middle Eastern culture? We have aniseeds. It's commonly used for abdominal pain, for colic, for anxiety, cough. Chamomile tea is very common. A lot of people use it for sleep and for stomach indigestion. Now, these can be okay to take when you have a patient, any patient, not necessarily a Middle Eastern patient, but you as a pharmacist, when you have a patient taking natural remedies. It's fine as long as you check for drug-drug interactions. Too much of something that's natural, too much of anything is harmful. And that's a point that we need to explain to our patients at all times. I have seen mothers, for instance, who give their babies formula milk, instead of water, they'll boil aniseeds and they'll put that as the base for the formula milk. Very common in Middle Eastern practice. They think it helps with a colicky baby. Now, if you read up some studies and if you look up on natural medicines and look up for these drug interactions or interactions of too much of a natural substance, you find that it has been linked to a lot of drowsiness in babies, a lot of fatigue, and sometimes even seizures. So it's not that if it's natural, that it's always safe. And that's the point that you need to explain to your patients. Again, there's nothing wrong with combining natural remedies along with actual medicine. But you have to, as a pharmacist, it's your duty to look into drug interactions, how much of a natural or an herbal supplement are they taking, how often are they taking it, and how are they taking it? Because sometimes some things are absorbed quicker in a certain way. Another thing that they use is ginger. Ginger, they use it for lowering blood pressure and as a blood thinner. Now, here's a problem. A lot of patients, a lot of Middle Eastern patients, have statistically been found to have more bleeding problems because they are already on blood thinners. So they're already on like aspirin, they're on Plavix, Xarelto, they can be on warfarin, and then they also take ginger. They drink a whole lot of ginger at home, so that thins their blood even more. So there's a lot of bruising, a lot of extra bleeding. Again, there you go. That's a drug herb interaction, just like we have a drug food interaction, drug interaction. Garlic is commonly used for insect bites, for hair loss, for warts. It helps lower blood pressure, cardiovascular health. A lot of this has been proven true, and we know that. But again, you want to make sure you're asking these patients how often they're taking it and what the quantity is. Another thing to look for when you're interviewing a patient at any time, and you're obtaining, let's say, a medical history on this patient, and you're asking for medications that they're taking. They will not consider natural remedies as medications because they're not. So it's your job as a pharmacist or as a student pharmacist to go that extra step and ask them, what natural herbs and remedies are you taking? Now, a lot of them might not understand what that means. Even a lot of first language English-speaking patients might not understand what that means. So it's your duty to explain, are you taking any teas, any herbs? Are you taking any vitamins or supplements? Define your terms at all times to all your patients, whether they're English-speaking or not English-speaking, because a lot of them will not understand that a natural remedy, or for instance, that taking garlic capsules that they bought from Walgreens or a CVS, can interact with any other medications if there is an interaction. But it's always good for you to know. A lot of patients, for instance, non-Middle Eastern patients I've seen in healthcare myself, take St. John's worts, and they take primrose. They're for menopausal symptoms, they're for mood swings, but the problem is that they also lower the efficacy of birth control. So there are always interactions between drugs and natural remedies, and it's your duty as a pharmacist to look into that. Another thing that is practiced, that is used in the Middle Eastern culture, is thyme. They use it like crazy. There are cough medications, prescription cough medications in Jordan, for instance, and other areas of the Middle East that are made with a thyme extract as a base. It's used as an antifungal or an expectorant. Black seed is commonly used by a lot of Muslims in particular. So not all Middle Easterners, but a lot of Muslims more commonly. It's known to cure all and treat all. So it's used for asthma, rheumatism, skin disease, cancer, postpartum strength, liver function, you name it, it's known to be helpful. So we talked about these Middle Easterners immigrating to the United States. In, let's say, in the 1970s, we saw a huge surge. Immigration is not easy. It is not easy on anybody, whether they are Middle Eastern or not Middle Eastern, because there are social issues that happen and that occur with these patients. So immigrants and refugees experience a lot of immigrational trauma. People leave their homes, they leave their friends, they leave their family. And just to give you a little story, there was a family that was over in the Middle East, and it was a mother, father, and two little girls. Normal life, going to school, the father has a job, the mother was a housewife, she took care of the kids. The father one day came home and was talking to his wife, and then a few days later he calls the two daughters home, and he tells them that they have decided to move to the United States for hopes of a better living and a better future for their daughters and better education. Now, the eldest daughter, who was 12 at the time, had a really hard time accepting that. She had to leave her friends, her family, her school, a lot of her toys. They couldn't carry everything over. So there was a lot of immigrational trauma that this family had experienced, not just as children, not just the children, but the parents as well when they traveled to the United States. They ended up traveling to the United States. It was very difficult for the father to get a job. It was very difficult for the mother to adjust or even get a job if she wanted to. There was a lot of language barriers, a lot of problems that this family experienced. So hold on to that story for a little bit. We'll get back to it in the next slides. Let's go back to social issues of immigration. We're talking about how immigrants and refugees experience this type of immigrational trauma, like the story that I just discussed. There's also a lot of cultural conflict. We live in the United States, and it is very, very diverse. We have immigrants from all over the world. So over the years, the United States became a very diverse culture. So it became Western culture, not American culture. It's a lot of Western culture, just the West in general. So it brought a lot of diversity to that pool. So all the incoming new refugees and incoming new immigrants find it very difficult, because then there's a culture shock. There's a different culture here that's practiced in the United States as opposed to anywhere else in the world. If you go to Italy, they practice their very own Italian cultural roots. If you go to the Middle East, very Middle Eastern. If you go to Poland, very Polish. Wherever you go around the world, people have held on to their culture. There have been a lot of immigration happening in the United States that we have different cultures, which is really nice, but you have to understand how hard it is on these immigrants when they first come. There's a lot of lack of social support systems. Again, people come, they don't know anybody, they've left their neighbors, they've left their friends, they've left their family, their cousins, their aunts, uncles, relatives, so there isn't much of a social support system when they travel. And cultural shock and exhaustion. So we talked about the cultural shock. It eventually is exhausting. So people actually go through a lot of mental illnesses, or just mental effects because of the impact of cultural immigration. Acculturation. So this is a big problem because a lot of patients will travel, let's say they are immigrants and they have traveled to the United States, but they refuse to join the culture of the country that they're in, even years down the line. It's okay for people to hold on to their cultural practices. In fact, that's beautiful. But in terms of medicine, they might still hold on to their own cultural beliefs. A lot of patients believe that, for instance, I saw a patient firsthand who takes his medications. He's a diabetic and he has hypertension. He takes his medications Monday through Friday, 5 days a week, and he lets go on the weekends. He takes medication holidays. This patient does that because he wants to give his body a break. So his goal and his whole point is that medicine will disrupt his liver function, and it's too harsh on his body, so he wants to make sure that he's giving his body some rest from that medicine. So acculturation, refusing to join a culture and going by your own practices that are normally practiced. So all this leads to increased risk of health problems, whether it's the immigrational trauma, the cultural conflict, lack of social support. It can be physical or mental, but it leads to a lot of health problems and risks. So the pathophysiological effects, immigration exposes them to a lot of dietary changes. Obviously, the diet here is different. Have you ever been to a country and you drank their water, you got sick, but then you wonder how everybody else in the country never gets sick when they drink that same water? It's because your immune system is used to something different than what their immune system is used to. So there's a lot of dietary changes when immigrants come to the United States. So they experience a lot of weight loss, or they can experience obesity, for instance. And then again, it enhances their risk of getting sick over and over and over just because they're in a different geographical area, so they're exposed to different microbes. Lack of immunity, and then a lot of risk of accidents in new situations. Everything is new when you're in a new country. The way they drive, the rules, the way things function, the way they build things, everything is new, and it's different when you're in any new country. So there's a larger risk of accidents happening. So a little bit about epidemiology. There are pool results from various studies that indicate that there have been several disease states found in these immigrants. Obesity was one of them, and it was found in 34% of the Middle Eastern immigrant population that have come to the United States. And it was found in all age groups. So these patients came not with these disease states, but this was an impact of immigration on these patients. And obviously they found a correlation where the obesity increased with age in these patients. And this obesity was known to be overall obesity as well as central obesity. Diabetes was found undiagnosed. So get this, undiagnosed in 10% of the immigrant population. So imagine 10% of these immigrants that have come are walking around not knowing that they are diabetic. And then they found that it was prevalent in 36% of the males and 54% of females. They also found that there have been several cardiovascular disease risk factors. So for instance, obesity, a low HDL count, high total cholesterol, high triglyceride levels, smoking. A lot of these patients smoke. We stress smoking cessation here in the United States. Other countries stress it, but maybe not to our extent. I have to say we are by far probably one of the most advanced, but not fully still advanced, but one of the most advanced countries in terms of pushing for smoking cessation. Just recently, some Middle Eastern countries started putting on the pack of cigarettes that smoking can lead to cancer and other issues and death and blah, 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 that little blurb that they put just recently. Now, you find some countries more advanced than others in the Middle East. Other countries do not allow smoking in public places. You want to smoke, you go home. They make it more difficult. But I'm saying that a lot of these patients come in smoking, and a lot of patients tell you that they're smoking because they're stressed. So again, that ties back to the whole immigration and problems of immigration that happen, as well as insulin resistance that happen in these patients. Cardiovascular disease was a high risk factor in the immigrant population. BMI was found above normal, ready for the number, in 92.2% of patients, a high BMI. It was higher in women than it was in men. And it was positively correlated with age, with blood glucose, and with systolic and diastolic blood pressure. Extremely high numbers. Total cholesterol of more than 200 was prevalent in 40% of males and in 38% of females. So just to give you an idea of how messy the case is in this patient population. Now, going back to the story of the family from the Middle East that immigrated to the United States. So this family ended up immigrating. Again, they had a hard time here. Like I mentioned, the father had a hard time finding a job. The mother wanted a job as well. The daughters were in cultural shock. They were in new schools. They didn't speak good English. The father has an accident and slips and falls. And he is in immense pain, more than normal, more than normal. So he ends up, this pain does not subside. It lasts several days. It keeps going, and he ends up going to the emergency room. He takes his eldest daughter with him, who knows some English, but not full English. She's 12 at the time. Excuse me. So this family, the father and the daughter go to the ER, and they complain. Their chief complaint is that he has side pain on his side. So the doctors in the ER run some tests. They looked at him. They thought maybe, okay, broken rib or something. Let's just do an x-ray. They did all the tests, and they found nothing. There's nothing wrong. So they sent him home, or they were about to send him home with just some pain medications to take for a few days, and then they were hoping it would subside. Now, the daughter kept telling the nurses and kept telling the doctors, he has a lot of side pain. He has a lot of side pain. And that's all the word usage that she could think of to try to explain to the healthcare providers that this is what's happening to her father. So the doctors dismissed the idea, and they're like, it's okay. It's not a big deal. We ran all the tests. Everything's normal. He just has a little bit of pain. It's soreness. It'll go away. Okay, so there was a lot of difficulty. First of all, access to care. Eventually, they had to come to the ER and couldn't go to their primary care providers. Second of all, there was a language barrier in the situation. The daughter and the father had a hard time explaining exactly where the pain was and what type of pain it was. And they were dismissed and not taken seriously by these healthcare providers, because what was the assumption on the other side from the healthcare provider? That they ran all the tests. They're okay. If it's just side pain, as they're saying, then they're okay. They failed to bring a translator, and they failed to explain what really is going on, or understand from the patient what is going on. So we'll get back to that story again in a little bit. Hold on to those thoughts. In the past few years, up until very recently, we saw a huge surge of refugees. So not just immigrants, but a lot of refugees, mainly from Syria because of the Syrian instability back over there. So a lot of these refugees started coming to the United States with problems that have occurred because of their situation. So they had a lot of anemia, a lot of diabetes, a lot of hypertension, and a lot of, as expected, mental illnesses. There were high incidences of acute and infectious diseases, again, due to their refugee status. A lot of them don't just come straight from Syria here. They've traveled across borders. They've picked up so many different bugs along the way and pathogens, and then they come here. But then they're coming here with a lot of there was a huge outbreak of like TB, for instance. I think around like 3 years ago in these Syrian refugees, because they came, they were untreated, and then they caught these pathogens on the way. This was because of displacement. Again, it's because of crowding. When they're in these refugee camps, they're in tight little tents together, usually families together at a time, not just one per family. It's because of poor sanitation. A lot of them, I spoke to some refugees, and a lot of them said that they would dilute medications like amoxicillin, for instance, for their PEDS patients from water, and very unsanitary water. This was the same water that they would just wash with, but they had no other option. They had no choice. So just to give you an insight on the difficult situations that these patients were in. They'd come with incomplete vaccinations prior to their departure to the United States. So a lot of them, for instance, if they had babies and they were displaced and they left their country, went to another country, then to another country, then sat on the border for I don't know how many days, weeks, or months, they're not out there trying to find immunizations for their children. Even if they tried, they don't have access. So that's another thing to look for in these patients. Just to give you a statistical idea of these Syrian refugees. So if you look on the map over here, anything in red is the more highly populated Syrian areas. So Illinois is one of them. So your chances of dealing with a Syrian refugee in the future, again, we have a lower refugee population nowadays coming in, but at one point we had a high population, and they are already here and settled. So you do have a chance because you live in Illinois and there's a high population of these patients and of you encountering these patients. So the epidemiology of these refugees, they come with acute illnesses and chronic illnesses. Some of the acute ones include tuberculosis, a lot of intestinal parasites, hepatitis B, and giardiasis. A lot of chronic diseases include diabetes, and I thought the stats were just ridiculous, and I thought I'd share them. Diabetes was found in 32.4% of these patients. Hypertension, 32%. Arthritis, 23%. Cardiovascular disease, 21%, still high. And then a lot of chronic respiratory diseases like asthma, COPD, 5.9%. So just to give you an idea of Middle Eastern culture, remember one of the learning objectives is that I wanted you to know a little more about Middle Eastern culture so that when you deal with these patients, you know how to handle them. Extended family is a central part of life. So when you're delivering care to patients, their family will probably be with them. Let's say it's a father, a son, or a daughter, or his wife, or somebody might be with them. Even a grandchild might be with them, an older grandchild. They like to remain close to the patient. They like to visit often. If they're in a hospital and you're a hospital pharmacist, you might see that the patient's family is always there. In fact, they might take shifts, like a morning shift, these guys come, a night shift, these guys come. The family expects usually to be informed by the doctor on the patient's status. They're there because they care. This is fine, and it is completely okay as long as you take the extra precautions to ask the patient if the patient is comfortable with you discussing this with the family, which you should be doing to any patient, whether they're Middle Eastern or not. So just make sure that the patient's okay, and if they are, that's fine. And we'll talk in a little bit about why that's actually to your advantage to use these patients' families when caring for the patient. They value privacy. So privacy within families is non-existent. Everybody knows everything about everybody. But when you're outside of a family, they are very private. So they might open up to you as a healthcare provider if you provide something they can relate to. And again, these pointers are, I'm talking about Middle Eastern culture, but my advice to you is general for all patients. This is how you should deal with every single patient. I have had patients, for instance, that complain about warfarin so much. And they find it so hard to take it because it bruises, and they're always adjusting the doses, and it's up and down, and it's not consistent, and they have to watch what they eat. And so I explained how I understood that warfarin is very difficult to handle, and how my grandmother, for instance, had difficulty with warfarin as well, and how she took some steps to stabilize her diet and to remain consistent with her diet. So that's just an idea of how I related to this patient, something similar to what they had, so that when I was talking to her, she immediately opened up, and you can tell just by her body language, she was more comfortable. She realized that there's somebody else in this misery. And she realized that it's manageable, that that other person ended up finding a way to go about it. So that's just an idea. Personal space, conversational distance in the United States is 5 feet. Okay, this is not 5 feet, but 5 feet. Conversational distance in the Middle East is 2. The reason they do that is because they like to explain, they like to look at body language. So Middle Easterners look for body language when somebody is talking to them. So they get a lot more closer. Now, you will find that conversational distance is shorter in all immigrants, whether they are Middle Eastern or not. And why is that? It's because these patients they have language barriers, and they're trying to understand and read your body more closely as you're talking. So again, that's just something to expect from a lot of these patients. They highly value medications. The Middle Eastern culture respects Western medicinal practices. They use spirituality and power and the power of prayer to alleviate a disease, which is good and bad. So it's good because that means they do believe that medications work, and they do believe that they need to take medications. It's bad because sometimes they do not question your authority, and you are human, and humans make mistakes. That's why it's bad. So you want to always, whether you're dealing with an immigrant or not, whether you're dealing with somebody of a different background than yourself or not, double check your work at all times. And that's because your authority is not challenged as a healthcare provider, and it should be challenged. So they might just completely trust that this medication is for them when this medication was for some other patient of a similar name or something of that sort. Another thing to keep in mind is that they use a lot of spirituality and the power of prayer. So a lot of patients will say, oh, I don't need this, God will heal me. I'm going to pray to God and God will heal me. It's okay to pray to God is what you need to be explaining to them, but you also need to take this medication along with the prayer or, the spiritual act that you will be doing. So just explaining that they go hand in hand, that they can still continue to do what they do, but this medication is also going to help as well. Now, Lipson et al. Identified some problems in Middle Eastern immigrants. Number one, as we talked about the language barrier, just like the story that I told you about the family that immigrated to the United States, they had a hard time speaking and a hard time conveying what was actually wrong to these patients. So English is not the primary language, like we discussed earlier, and these patients can't truly and effectively express their signs and symptoms because they lack basic terminology. So when the daughter of this immigrant father at the ER was saying side hurts, maybe that's not what she meant. Maybe something else was hurting, but she couldn't think of any other words to put together other than side and hurt. They are very passive in the presence of a healthcare provider. So you'll get a lot of patients that will nod. I get a lot of patients, for instance, that nod who are American-born patients, but they nod because they don't really understand what I'm saying. They're hard of hearing, or they're very old, and they have no idea what this new medication is for or what to do with it. So they're very passive. And then they're resistant to disclosing personal information. They do not want to disclose. Again, it's that whole value of privacy. In the family does not exist. Outside of the family, it's a huge thing. So always relate to them with something to help them give you a way in, basically. Possible issues you may encounter: females refusing male healthcare providers, or vice versa. So this is very common in Muslim patients, just because of Islamic teachings and the code of modesty. For instance, as a future pharmacist, let's say you are a male and you're delivering flu shots, and you get a Muslim patient who says, is it okay is there a female pharmacist? I'm more comfortable with a female pharmacist doing this. So just make the accommodation, maybe tell her when to come back and at what time, and she'll be administered the vaccine by a female pharmacist. Try to accommodate for these patients. For instance, if you're delivering, if you're doing a blood pressure screening on these patients, females might be reluctant to pull up their sleeves in front of a male patient. So some patients might tell you, I just want like a private area. So then you can go ahead and put them there. Others might say, I prefer a female because I'm a female, or I'm a male, I prefer a male. Again, it's due to the Islamic code of modesty. Easy fix. Just try to make that accommodation. Language barriers are huge. A lot of these patients have basic or no English. Patients may nod as a sign of understanding, but in reality, again, they don't understand. So this causes a lot of miscommunication where you might actually need to translate. So you can resort to a translator if you're in a hospital. They have those easily accessible. A lot of patients use Google Translate or even medicinal apps that actually help you talk as a healthcare provider into the app, and then it'll tell the patient. And as I always say, use layman terms with all your patients. You need to be very simple in your terminology. They will not understand a lot of things. Okay, so like we said, body language is key when dealing with these patients because they will try to understand you through body language. Another way to help explain something to a patient, let's say there's something with TID or BID dosing. I've seen a pharmacist once, back when I was a student, actually draw out a sun and a moon on a piece of paper, and she put one tablet here and one tablet here, and the patient was able to understand that this is for the morning and this is for the night. So it's very easy to find some sort of universal language to connect with your patients with. And this patient was not a Middle Eastern patient. It was just, he was a patient who was non-English speaking and very old as well. Another issue you might encounter is the family being on the patient's case at all times. This, like I said, is okay. They might want to sit near the patient. They want to be involved. They'll ask questions. They would want to be updated. As long as the patient is okay, this is actually to your advantage, because then you can use that family as encouragement, social support, motivation for these patients. So you can get the family involved on the patient's case as well. So, you know, once the patient is home, they're well taken care of, and the family member is on top of their medications and how to administer them and at what times and all that. So it's actually to your advantage if you use it properly. This is just a case scenario I wanted to share with you. A 50-year-old male states he only takes his medications on weekdays, and that's because he wants to give his body rest. So this is the example that I used previously. Very, very interesting. I mean, that we had to end up explaining to this patient that these medications are titrated well enough for your body, and they go through several testings before the FDA actually approves them. Yes, there are side effects, and yes, there are bodies that can't handle certain medications and actually have adverse effects. But you know, you've been taking it with no impact. You cannot take drug holidays, medication holidays. So we ended up explaining that to the patient and then following up after. Another one, which I found was very interesting, is a 70-year-old female gets her diabetes medications filled in her home country, Egypt. The last time she saw a physician was 4 years ago, and today her blood glucose was elevated. I remember her blood glucose being in the 500s. And she's like, well, I get my medications from Egypt, but no one has been back from Egypt anytime recently, so I'm not sure when they're going to come, and I just haven't been taking anything. Canceled her, sent her to the ER, obviously. So these are just things to understand when you're dealing with patients of different backgrounds than yourself. Common Arabic terminology, the hijab is a headscarf. They might say Alhamdulillah, which means praise be to God. Inshallah is God willing. So if you tell a patient to take this medication morning and night, they'll be like, Inshallah, which means God willing. Shukran is the Arabic way of saying thank you. Hello is marhaba in Arabic. And if they're Muslim, they'll say peace be upon you as their hello. Assalamu alaikum or salam. These are just some Arabic resources in case you're not busy enough in Arabic school and you want to learn a little bit more Arabic. Like I said, as a healthcare provider, there are plenty of applications that you can actually look up and find that you can use yourself for these patients. So this is just to give you an idea on how to deal with the patients that you will encounter in the future, because again, we live in a diverse country. So to go back to the story of the girl who immigrated with her family to the United States, they're at this point in the ER, they are about to get discharged, and her father are still insisting that there is pain, and the girl is sitting, 12-year-old girl, with a bunch of other healthcare providers telling them his side hurts, and this man looks like he is in immense pain. Eventually, a nurse comes in, and the daughter again keeps repeating side pain, and she's pointing to her side. Now they did a workup for front pain, so they thought like stomach, they thought rib cage, they thought something like that. So a lot of the nurses eventually told her, it's okay, don't worry, the doctors know what they're doing. We're getting your papers ready. He'll feel better in a few days. And this girl still insisted. Another nurse came, and she was talking to the daughter and eventually realized that there's clearly a language barrier, so she brought a translator. And they brought the translator, they talked, they brought the doctor back in, they did further testing, and it turns out that this patient, this father, had acute kidney illness. He had AKI, and that's because he was still taking his hypertension medication that he had received overseas and taking his new hypertension medication from this doctor here, that his primary healthcare provider, without anybody doing a medication reconciliation. So nobody did a med rec on him. Nobody told him to stop taking the other blood pressure medication and only take one. And no one updated him. And so his kidneys got hit. So he had a high creatinine clearance and he had AKI. He was diagnosed with AKI. Now it resolved and it was fine, and he was discharged properly now with the proper paperwork, proper counseling. Again, the translator was key in this case. Ladies and gentlemen, that girl was actually me. That was my family who had immigrated to the United States, and it was us who found it very difficult to access healthcare and to just be in the American healthcare system. So that's just to give you an example that patients actually do struggle, and we have to, as healthcare providers, be mindful of their struggles and how difficult it is for them to access healthcare. So with that, I do conclude. I hope you learned a lot from this lecture. If you have any questions, feel free to contact me. And thank you.